Hans? We cannot hear you. Hans? We cannot hear you. Yeah, now we can. Are you going to start, Hans?
I'm going to start, yes. There are still persons coming in, but let me start by saying to you, welcome to all the speakers, the panelists, and the attendants of this webinar on stigma of mental illness and COVID-19 cultural perspectives. This webinar was initiated by two special interest groups of the World Association of Cultural Psychiatry, the SIG on Stigma and Discrimination, chaired by Maosheng from Hong Kong, China, and the Emergency SIG on Cultural Psychiatry and the COVID-19 virus pandemic, chaired by me. Together with great help from Roberto Luis Fernandez, the president of the WACP, and from Ji Li and Tianming Zhang from China, and Albert Persaud from the UK, we have made this program of this webinar and have found 4 excellent speakers on this topic who are willing to present a lecture. Dinesh Bugra, Melanie Escaño, Cecile Rousseau, and Winnie Mack. They will be introduced later, but I want to thank them already in advance. Stigma of mental illness and the effects of COVID-19 on cultural psychiatry seem to be 2 different topics. Yet we have found many similarities and connections between the 2. People get stigmatized when they belong to specific populations like ethnic minorities, migrants, poor people. But also psychiatric patients get stigmatized. And COVID patients or unvaccinated persons by any reason get stigmatized. When these 3 groups come together, stigma and discrimination gets worse. We hope to give you today enough information to understand this problem. But also we want to discuss possible solutions also with your help. At the end, we will ask you to participate with us to do so. Maosheng will come back on that, and you will find our own email addresses also on the WACP website under news. But first, I will ask Roberto to give a short welcome. Roberto, up to you.
Thank you, Hans. I want to welcome everyone as well, and thank you for taking the time to join us today. And to echo what Hans said about inviting you to join the World Association of Cultural Psychiatry and participate in its activities. WACP is a truly global cultural psychiatry organization of individuals from all disciplines who are interested in cultural psychiatry and who work together to promote clinical practice, research, and training. I also want to take so we really want you to join and participate in everything we're doing. You make it possible to actually have these activities. And we want to take the opportunity now, as Hans said, to thank the presenters in advance and the organizers of this webinar. Welcome.
Okay.
One last remark. Don't use the chat for questions. Use the Q&A. On the Q&A, you can see your own questions and that of others. So we will take questions from the Q&A. Thank you.
Okay, thank you, Hans and Roberto. So now,
I'm sorry, Maosheng, my apologies. It's my turn to introduce you. I should have done that at the end. My apologies. Now we turn to Dr. Maosheng Ran, who is Associate Professor in the Department of Social Work and Social Administration at the University of Hong Kong, and the Chair of the WACP Special Interest Group on Culture, Stigma, and Discrimination.
Thank you, thank you. Thank you for your introduction. So now let's go to the first speaker. Yeah, the first speaker, we welcome the Professor Danish Bergram, and He is an emeritus professor, mental health and culture diversity at the Institute of Psychology and Neuroscience, King's College London. And he is a past president, World Psychiatric Association. So please, Professor.
Thank you very much. Thank you, everyone, for inviting me. It is a great pleasure and an honor to join you this afternoon. So let me try and, right. I need permission to screen share. It has been disabled. What I'm going to do over the next 15 minutes or so is to share some findings from the UK data. I'm going to focus very much on UK experience, which is about, I'm not going to go through the various right, I am lost in that. For some reason, I can't see the
You have to find, you find your,
yeah, I think it's sort of saying that I can't seem to see it. Anyway, let's carry on. I think one of the big challenges in the UK has been the spread of, sorry, I'm sort of still struggling.
If we could pause for a second, Dinesh, I think it would be good for you to find your slides. So so let's just pause the presentation for a minute while you do that, if we can.
See, just when you thought it was working fine, it's gone. Right. Okay. Can we see it now or not?
Not yet.
Okay, let me start again and see if we can. Yep. Is it visible
Great.
now?
Yes.
Yeah, it's good now.
Okay, thank you very much. Thanks for your patience. My apologies. We know that, I'm not going to go through various history, but I just want to focus on two things. And one is the impact on general population, especially Black, Asian, and minority ethnic groups in the UK. And secondly, on people with psychiatric disorders. But equally, I think we need to bear in mind the mental health related to COVID patients and those who have recovered. And certainly when COVID hit the UK in March, there was a sense of fear followed by anxiety, followed by anger, and then depression and some kind of acknowledgement and acceptance. And we know that in the previous epidemics, we've seen high levels of anxiety, self-medication, high levels of alcohol and substance misuse. And it has been argued that levels of post-traumatic stress disorder go up. And there is also worth bearing in mind that survivor guilt, and there are specific issues related to healthcare workers. And there are challenges about lockdown and gradual opening of public places and what happens. And I'm not going to go through the whole anti-vaxxer arguments, which has created problems. But certainly in the UK and like elsewhere, there's been problem in using terms like social distancing. I think just when we needed to be socially closer but physically distant, we've been giving very mixed messages. These terms do matter, and the lessons from the UK, Brazil, and United States have been, there's been disjointed thinking and problems in communication with the population and how political decisions are made and who makes them. And there are factors related to isolation, loneliness, and working from home. Last count, there were nearly 500,000 studies on mental health. And every day there are studies emerging, so it's very difficult to keep up to date. And there is certainly overdiagnosis of anxiety, depression, and just a note of caution in terms of interpretation of the data. And we want to focus on race, gender, and poverty. And we know, particularly in the minority ethnic groups in the UK, there are higher rates of physical disorders like diabetes, hypertension, obesity, osteoarthritis, arthritis, chronic pulmonary obstructive disease, etc. So they already impact upon mental health, and then COVID on top of it can create problems. This is a major challenge, particularly in the UK. There have been structural racism, and all the politicians seem to ignore it or not acknowledge it. Even during the lockdown, Blacks have been stopped more often and disproportionately. If you are a whistleblower in the hospital and you belong to a minority group, you're less likely to be listened to. And low-paid frontline and care home staff have had problems in accessing personal preventive equipment. Rates of death among Asians have been 1.5 times higher. Among Black Caribbeans and Black Africans have been 2.7 to 3.2. High among, even within South Asian population, highest among Bangladeshis, followed by Pakistanis, followed by Indians. And this has shown that the risk of dying is, following positive tests, is marginally higher in the Indian group, but reasonably higher in, not reasonably, but much higher in other Black groups. If you have diabetes and certain types of diabetes, you're much more likely to die because of COVID. And then this has been confirmed in studies from America, and American community surveys shown that rates were much higher in non-Hispanic Black individuals. This has led to much higher rates in the USA, and particularly in certain states like Kansas, Michigan, Missouri, and Illinois. COVID age has been a formula which has been used in the UK, which indicates that certain vulnerability factors can contribute to age. So, for example, a healthy white woman aged 40 has a COVID age of 35, whereas a white man aged 45 with BMI, with severe BMI 36 with severe asthma has a COVID age of 69. So it's something that we just need to bear in mind. And BMI particularly adds a number of years. If it's over 40, then it adds 10 years to age, as does diabetes and other physical conditions, which, as I said, are much more common in minority populations. And the rates are much higher in Black, Asian, and minority groups. But when Public Health England did a qualitative survey, they, particularly in the minority ethnic groups, they expressed deep dismay, anger, and fear because many had lost colleagues, and largely a lot of them, this was due to structural and societal racism, socioeconomic factors, because people worked in public transport. We heard about bus drivers being spat upon, Chinese takeaways being attacked. So there's a whole range of social and cognitive factors which are related to racism and discrimination. And similar findings emerge from this meta-analysis of 18 million individuals, mostly from the USA, but also including UK, which showed high rates of ICU admissions and death. And there are other factors that we need to bear in mind, which are to do with, as I said, rates of infectious disease, but also differences in lifestyle and diet, etc. And I'm not going to go through gender. We know that the rates of domestic violence have shot up against women and girls really significantly in various countries, in France, Argentina, Cyprus, Singapore, Canada, Germany, Spain. And there are challenges related to gender roles and economy. And this has been seen in previous pandemics of Zika and Ebola. So the key messages from COVID are that there is impact of long-standing social and economic inequalities, increased risk of exposure and complications, and racism, stigma, and discrimination. And I'm not going to go through the challenges that racism creates, because this is about inherent privilege, but everybody listening to this webinar has at least one prejudice. And I think that is something that we need to bear in mind. Prejudice, racism, and classism are interlinked and they go together. And the prejudice can create problems in terms of seeking help, in terms of stopping people from going to hospitals, and institutionalized racism, which is about creation of the other. And if we have time in Q&A, then I can cover a bit of that. But what is significant is that this leads to social marginalization and further stigma. And we know that clinicians have their own prejudices and unconscious biases that we need to be thinking about. But stigma, in a way, has a significant role to play, because that creates the other, and that's about identity. But what we also need to bear in mind is discrimination, which is institutional, which can be legal, which can create more problems for minority groups, no matter where in the world we are. And that needs to be really challenged. And part of the role for clinicians is to create their responsibility as advocates so that they can try and challenge these discriminations. So just to conclude by saying that there's very clear evidence from the UK that there are variations in infection rates and race, and these causes need further detailed exploration in the context of stigma, in the context of institutional racism, in the context of privilege, and social determinants in the context of geopolitical determinants need to be remembered. And part of the challenge really is that we may need to compare across countries and see how that fits in. And clinically, we all need to have very clear competence needed to reduce structural racism. So once again, thanks very much. I do apologize if I've gone over my allocated 15 minutes, but very happy to take questions now or later. And you're very welcome to contact me directly if you need any further information. So thanks again for listening.
Thank you very much, Professor. I just, we do like your just a very meaningful and informative presentation. The question, Q&A part where maybe some people will ask your question. Thank you very much. Thank you very much. Now let's go to the next speaker. Melanie Escano, and she is one of the founders of Filipino Migrant in Solidarity, and representative for migrant domestic worker and network of the Dutch Federation of Labor Union. Now, please welcome Melanie.
Thank you. Hello, everyone. First and foremost, thank you everyone for inviting me today in this event to represent the undocumented migrants. My name is Melanie Escano. I am from the Philippines. I have been in the Netherlands for the past 16 years, and I work as a domestic worker. I work for multiple employers in The Hague, though I am undocumented. As what Maosheng said, I am one of the founding members of the Filipino migrants organizations in The Hague, which we call FILMIS. And I'm also an active member of FNB Migrant Domestic Workers Union. I feel privileged to share with you my story about the effects of the pandemic and lockdown on me and to my fellow domestic workers and other undocumented migrants. Let me emphasize that my story is just one of the many stories of undocumented migrants in the Netherlands who faced an uphill battle to survive during the pandemic. In essence, the pandemic showed up as health crisis, but it affected us on all other fields of life, also financially, emotionally, psychologically, and physically. Let me begin my personal story as undocumented migrants in the Netherlands before the outbreak of the coronavirus. Like most of the undocumented migrants in the Netherlands, I tried to conceal my real identity and status to avoid the risk of being deported. I work as a domestic worker for multiple employers. I clean 2 to 3 houses a day from Monday to Friday. Sometimes I do babysitting and house sitting on a weekend. As undocumented worker, I don't have any access to social security such as health insurance, shelter, and unemployment benefits. As far as shelter is concerned, I don't usually stay long in one house. And I always move from one place to another whenever there is inspections by the city government or by the police. However, despite of my status, I try to live a normal life in the Netherlands. Before the pandemic, I have had an active social life. Because of my involvement in different activities of our organization's Filmis, which stands for Filipino Migrants in Solidarity. We have two main objectives. First, to promote the education of migrants and their families. And second, to promote the human rights of migrants. In the past years, we organized fundraising events for the education of poor children in the Philippines. I was also involved in various campaign activities that promotes the rights of domestic workers in the Netherlands. On a personal level, I also used to attend social gatherings with close friends who were also undocumented migrants, such as birthdays, anniversaries, and other special celebrations. Those were the days where you could never think of any danger of acquiring a virus from people with whom I had a physical contact. Those were the days I interacted with friends in a spontaneous way without any fear of danger of acquiring a virus. But when the government imposed a lockdown last March 2019, everything changed so fast. Health restrictions against coronavirus were implemented nationwide. Sad to say, COVID-19 pandemic has made my social activities a thing of the past. During the first week of lockdown, my life changed dramatically in a way that I could never have expected. Most of my employers actually decided to cancel my work until the situations would get better. They gave almost all the same reason. Of course, they are afraid of getting an infection. The sad thing was they did not pay me during the lockdown. In general, in our work, social security is not very developed, which was of course already a problem before the pandemic. During the lockdown, I lost so much income. I could barely pay my rent out of the wages that I received from those few employers who had allowed me to continue to work in the houses despite of the pandemic. I stopped sending financial support for my family in the Philippines, which was and is also suffering from the COVID-19 crisis. I used my small amount of savings to buy food for my daily sustenance during the first months of the crisis. I would say that the life of undocumented migrants in the Netherlands during the lockdown was difficult due to lack of social protection. My struggle to cope with it took a big deal of adjustment on my part. I don't have a choice but to confine myself in a small room most of the time. I felt like a prisoner inside my room. I stopped visiting my friends in their houses. In the same way, they stopped visiting me in my room for the same reason, fear of the coronavirus. All activities, gatherings, and meetings face-to-face had actually stopped. I hardly saw my circle of friends in person during those weeks of the lockdown. But we tried to keep in contact with each other most of the time, either by phone or social media. During those times, many questions pop up in my mind. Every time I woke up in the morning, I would think about my situations as undocumented and my family in the Philippines. What if the government prolonged the lockdown? Where would I get money to buy food and to pay the house rent or the room? What if nowhere we can pay cash anymore? And if every establishment required PIN, how could I buy food to eat since I don't have a bank account? What would happen to me if I caught the virus? Who would support my family? All this kept bothering me night and day during the lockdown. I heard cases of undocumented who were kicked out of their rented houses. And all of us live under the fear that this would happen to us too. People who borrowed money from others to buy food have to pay interest over this. People who felt symptoms of coronavirus but didn't know how to go to the doctor because there were no clear guidelines for people like us who have no BSN number or social security number. I was even thinking of people that I knew who had died of coronavirus in the Philippines. I could not fathom out of a thought that people whom I know today would be dead tomorrow. I asked myself, is life so short and meaningless? These thoughts actually gives me a feeling of uncertainty, anxiety, and fear. There were a few times I got so nervous when I felt something bad in my body because I was always afraid that I might have caught the coronavirus. As I said, COVID-19 pandemic affected me physically, mentally, and emotionally. My struggle to cope with the situation didn't stop within the four corners of my room, but rather it extended over the streets. The first week of lockdown, it was so unclear what was going to happen. As Asian people, we met distrust and people shouting at us for causing the pandemic. It happened to some of my few friends who experienced different forms of discrimination. There was one who, while walking on the street, got mocked by a stranger by calling a Chinese virus. Go away. Since then, I got worried because I look like Chinese too. If it happened to my friend, it might happen to me too. All these worries and fears during the first week of lockdown did not only change my life, they also changed the way I defined my life and the world around me. For me, I started viewing my life as becoming hopeless. I felt that I was losing my grasp of directing my own life. I could not even think and plan the way I would like for my future because of the precariousness of the situation. I felt my sense of freedom as a human being was disappearing. I felt a sort of loss of purpose of being human because I could no longer do the normal things that I usually did before. I felt in disarray because many things cramming into my mind that were beyond my grasp to fix, especially the conditions of my family members who were facing the long lockdown due to crisis or the rise of cases of infections in the Philippines. And my situations where I was trapped without enough jobs and money, and my worries that I would never see my family back home. How I deal with the pandemic being undocumented? I must say that having an organization was a blessing for me and for our undocumented members as well. We suddenly received a news that big organizations were willing not only to help us, but to tap us to help others. Our organization's films serve as a bridge between Dutch organizations and the people directly affected. During the lockdown, together we managed to help many in a very practical way. Filmis collaborated with these organizations in getting financial assistance for undocumented Filipinos who lost their jobs due to pandemic. Indeed, I was one of the beneficiaries who received assistance from the World House for the payment of rent and food. The assistance helped me a lot, not only for my financial problem, but also my psychological and emotional distress. As a beneficiary, I also serve as a volunteer for them to reach out to more undocumented Filipinos on the ground who were affected by the pandemic. We entered into a contract with Red Cross as a party which was responsible in organizing a food relief operation, not only for undocumented Filipinos, but also for undocumented Indonesians and Latinos in The Hague. We distributed food cards to them every Sunday in the church. With the help of our network, we were able to partner with PGD in organizing a mass vaccination for more than 300 undocumented migrants from Filipinos, Indonesians, and Latino community in The Hague. It was an amazing success. And this was followed by another mass distributions and stamping of international vaccination booklet from KKD, also in the same church. We look back to this period as a good example of cooperations and the right policy. We commend the KKD for the job well done, and we hope it stays open for the collaborations. And we value the cooperations with organizations and municipality to protect the most vulnerable inhabitants of the city. I believe that the effective way to address the pandemic is these adoptions of a policy of inclusion, a policy that guarantees no one is left behind during the crisis. So I can say that we had a good experiences and we see the way it should be done, but the pandemic is not yet over. We hope we can trust that we can continue to work together and follow the developments also from the view of the most vulnerable in our society. However, we have worries. The implementations of a QR code in the Netherlands has rendered the yellow vaccination booklet useless as a proof of vaccination. Worse, it has pushed the group of undocumented migrants one step backward to isolation since we cannot obtain the QR code. We are already not allowed to enter certain establishments such as restaurants, theaters, cultural gatherings, etc. The voices get stronger that also employers have to ask for it. With these measures, undocumented people, also when they are vaccinated, will be excluded again. It made our world smaller and more dehumanized. This brings unrest and fear among our communities, and a solution needs to be found for this. We wish the Dutch government would address these conditions for the undocumented rather than waiting for another pandemic to strike again. We wish they gave us an access to social protection. And I do hope that my experience and the experience of many undocumented migrants during the pandemic will provide mental health experts like you with some insights into the psychological and the emotional effects of the lockdown. Yeah, thank you.
Thank you very much, Melanie, for this personal story. And please keep your video on because there are some questions. I wanted to ask you, you noticed that undocumented migrants have more problems at the moment because everything is more official now with the 2G and the 3G measures.
Yeah.
Is it possible for you as undocumented migrant to get an entrance at the moment when you are vaccinated, or is it still not possible?
We can be vaccinated, but the major problem with us right now is the QR code, which is implemented nationwide. And having a QR code, you need to have the social security number.
Yeah.
So, and the majority of the restaurant, they don't accept even we have the vaccination card that proof. Still, they did not acknowledge it. So, yeah, we do have experience that some of us already in the restaurant eating, and they control, and then they were asked to go out and take their food outside because they don't acknowledge the registration card.
Okay, thank you for your lecture. We have also some questions for Dinesh, and there is a question from Roberto Dinesh, and he asks me what are the similarities and differences in the stigma and discrimination faced by people with mental health problems as opposed to COVID? Does it matter, for example, that we are in the midst of an acute pandemic of COVID versus the more endemic nature of mental health problems?
Thanks very much, Robert, for that question. I mean, it is difficult to tease out what's going on because the pandemic has meant that there's been a lot of sort of xenophobic nationalism and racism, and the fact that Chinese restaurants were attacked when pandemic hit, and as if kind of virus distinguishes between races just because the origin was set in China. So that created quite a lot of xenophobia and consequent racism. So stigma, in a way, is a global phenomenon. It's a global issue. It kind of presents itself in very different ways. COVID complicates it for two reasons. I mean, one is that it is seen as an external factor, which is, we would have been safe if we didn't have migrants, or those kind of idiotic thoughts people have. And the fact that we were not helped by politicians. I mean, in the USA, you had even more horrendous experience when your previous president was saying really unacceptable things. So in a way, what that has done is sort of created this ongoing sense of bewilderment, and people from ethnic minorities who suffer from COVID, and they've consistently shown higher rates of mortality, are suffering from a double jeopardy. Because if you are working in frontline, and most of the frontline jobs in the National Health Service and in public transport and so on and so forth are, like in America, are done by minority individuals who are more likely to be attacked. They don't have the resources. It's a gig economy where they cannot live in isolation. And we heard from Melanie, which is similar but slightly different example, that you don't have money unless you can go out and get a job. You can't feed yourself, you can't feed your family, and that isolation and loneliness create further problems. And if you're not able to access health services when you need, and the other factor that has emerged, certainly post-vaccination, is that ethnic minorities are far more likely to be vaccine hesitant. And again, there are lots of historical and cultural reasons for that we need to explore and deal with.
Thank you. There's another question for Melanie from Mario Braakman, who is the coming president-elect of the WACP. Melanie, if you were the Prime Minister of the Netherlands for a moment, what would you change in the policy in order to do justice to the undocumented migrants?
To the policies, I think to include us, the inclusions. I mean, for the policy, they should not put a barrier who are undocumented and who are not. So the inclusions in the policy that everybody should, nobody should left behind. And I mean, although we are have an access with the vaccinations, still we're also left behind. And also to give us a social protection, even we are undocumented, we also deserves to be protected by the government.
Okay. And I have another question for Dinesh from Maosheng. As stigma on COVID-19 and racism are sensitive issues for many countries, so how to conduct comparative studies across countries, for instance, Asian countries and the US or the UK? How could you do research on that?
I think there are some sort of fairly straightforward comparisons. I mean, we did, when I was president of the World Psychiatric Association, we did a survey of laws of 193 countries, and all 193 countries were signatory to the United Nations Charter for Rights of Persons with Disability. And we looked at 4 rights: right to vote, right to marry, right to inherit property or make a will, and right to employment. So we looked at laws, which is, if the laws are discriminatory, then, we have a problem. And we found that only about 40% of the countries allowed all 4 rights. So something like that is easily comparable. The other way to do sort of cross-cultural comparison is to combine quantitative analysis with qualitative work, and do not use sort of the questionnaires blindly. They have to be developed within the culture, and what they need to be doing is be supplemented by qualitative work both before and after. And again, when we looked at attitudes towards depression in Dubai and creating Dubai depression inventory, we started off by interviewing 100 people, purely qualitative, to understand what terms, and from that we isolated the terms people use to express feelings of depression. And then we shared those 73 items, or I can't remember the exact figure, but fairly high number, with medical professionals of all disciplines to try and understand what terms people would use when they appear in the clinics. And that reduced the number to 20 something, which we then compared with the MMPI, which had been previously validated. So I think the qualitative and quantitative pieces of work need to go hand in hand to make sense of people's experiences. And that's what makes cultural psychiatry so interesting.
Thank you. Maybe just a short question for Melanie still. We have, in fact, no time, but this question is very nice to pose from Brian Hall. What steps do you think, Melanie, that the mental health community can take to work with you in solidarity to improve the mental health of migrant Filipino domestic workers?
I think what steps do we, I think we want to, if you can join with us and support us with our campaign to the government, that for us to be included in their social protections, because we do have campaigns here in the Netherlands. Being undocumented is it's not easy. So we have some campaigns that the government to give us a fair social protection like everyone else. Okay. Because we are human beings, so everyone has deserved social protections.
Okay. I think we have to close the question and answers now. I hope that you still be with us. And I have to introduce Cécile Rousseau now. Cécile Rousseau is coming in. She is a professor in McGill University in Canada, and she's also head of the Division of Social and Cultural Psychiatry in Montreal, Canada. Please, Cécile, if I do short, please tell us more about yourself, but you can have the floor now.
Thank you very much, Hans. And I'll share my screen. Good. It's a real pleasure to be with you this morning. Well, morning in Canada, afternoon for you, most of you. I just was thinking, so it's a pleasure to have this conversation. I think it's very important to have this conversation across countries, not only to share experiences, because as Melanie was telling us, this has been a painful process for a lot of people, and we have to hold this pain, certainly as mental health practitioner, and be able to face it, but also because we need to learn something from this crisis, and we need to do it better next time. And if I had in a nutshell, and then I'll share some research data, but I had in a nutshell to tell you kind of a key message, it would be, we had it all wrong because we thought we were equal in front of the virus, and obviously we're not. And next time, and that as things go on, we have to think concurrently mental health, equity issue, and the pandemic control. By just focusing on the pandemic control, on transmission, and on vaccination, we in fact increase social problems and mental health problems in a way which may make them worse than the pandemic itself. So that would be my key message. Now, let's go on to see a bit, as a mirror what Dinesh was saying, what is the situation in Canada and what did we learn of what was going on here? So I'll present you some research data from we had a number of studies, as Dinesh said, during the pandemic in all countries. And so some of the key messages. So allow me to jump over the methods. We can come back to that, and all of that is published, so you may access it if ever you want. So the first study was we oversampled in the Montreal area migrant and ethno-cultural and ethno-racial groups. The results of the first set of results of that study showed what Dinesh also stressed, that exposure was unequal. So there was more exposure in especially the Black and the Arab community. And the main reason why is that they were part of the essential task force, which was more exposed to the virus. Now, the prevalence of COVID-related discrimination overall was high. So you see where we were over 16%. And visible care minority, essential workers, and essential worker were experiencing these forms of discrimination. So we are in an intersectional model where multiple reasons may lead you to experience stigma and discrimination, and this has impact. And one of the first impacts we documented is the documentation of COVID-19 stigma and perceived COVID-19 discrimination and social distancing. And this kind of goes along with the work on Ebola. We also work very much with Jude-Marie Senna, who's working in Congo and 6 other low and middle income countries on the issue of Ebola and COVID. We have the same result in those countries and in Canada, which is the more stigma, the more discrimination you experience, the less you will adhere to social distancing. And I agree with Dinesh, care about the word, but with sanitary measures. Probably, and our interpretation with some qualitative data is that you have the interference come from the fact that if you feel stigmatized and discriminated, you want to be as invisible as possible. And so you will not disclose that you're at risk. And sometimes you cannot disclose that you have symptoms because your family cannot live otherwise and you cannot afford to not have a job. The other reason is being stigmatized or discriminated creates an illicit anger. And if you're angry, you may also say, why should I care? Why should I protect other people when in fact I'm under attack? So COVID-related discrimination and mental health was clearly, there's a link which was clearly established. And in our sample, Black participants reported worse mental health outcome when they were exposed to COVID-related discrimination. So you see, it's a moderation relation. Globally, COVID-related discrimination was associated with higher mental health distress, but again, this is not equal across communities. And it's for the Black community that there was more impact, which is not surprising when you think that's what's happening in North America. Think of Black Lives Matter, which of course had echo in Canada. So we do not have exactly the same social panorama than the state, but this is certainly significant for us. And we could document, this is a kind of a large scale survey, that there was measurable impact for the Black community. Now, that's a complex schema. I don't want you to read all of that, but just let's say that on the right side, you have the negative of confinement measures, okay, social isolation being, of course, and social restriction, one of the worst in which everybody converged. And then on the right side, you have the positive of confinement. The reason why I'm bringing that is very often we forget in adversity or in crisis situation, we focused on what is dramatic, what is painful, and we forget to see that even crisis may have positive elements. And it doesn't mean that they are positive, but it's very important to identify those positive elements. If we want to protect community and be able to work to enhance community resiliency, which was in fact very, very strong during the whole pandemic, certainly in Montreal, Quebec, and Canada. So the green light up there in the sky is about people who experience much more adversity, much more negative effect of the confinement. And of course, their mental health was more affected, and you had a clear factor of race and ethnicity in this group, which was more at risk. Now, if you look at the red line, you have a group of youth, among which people from different ethnicity and race, who enjoyed the freedom of the confinement. That gives them an escape, a capacity to escape the constraint of institutional life and the constraint of jobs, which are often not easy. And then you have another protective effect, but I won't go in details, of family. So the whole idea is spending more family time, even if you have much more conjugal and family violence in some family, but for other family time was clearly protective. Having freedom and escaping from job constraint was also protected. So thinking all the balance of these potentially positive things, which also interact with ethnicity and race, which the confinement can bring, is important if we can think in terms of how do we mitigate the effect of the pandemic. just wanted to mention another study that we did, in fact, more recently, because the first one was done at the beginning of the pandemic. And I agree with Dinesh that the spring 2020 elicited acute stress reaction with a kind of a major anxiety reaction in the whole population. While from autumn 2020, we switched to a chronic stress reaction with major elements of avoidance, frustration, anger, acting out, and risk-taking with the concurrent conspiracy theory. So it's during that time, and so this is a study which was done in December 2020. So we are in the chronic phase of the reaction to the chronic stress reaction of the pandemic. And it measures the concurrent social adversity experience that people have experienced during the pandemic, with the idea that they may be cumulative. So it's a sample of young people, so below 40, from 18 to 40, and we'll look at the cumulative effect of COVID discrimination, cyberbullying, traditional bullying, on the legitimation of violence, and on psychological distress. So the whole idea, you know, young people and all of us were very much online, like we are today during the pandemic, which was again a blessing and a hurtful process for some, because violence online also increased tremendously. If you look at threat, insult, hate discourse online, they increased, as well as, of course, the online space was a place of resiliency, support, and replacing the social support that was not available. So in this study, we kind of investigate the relation between these relations. And we found a cumulative relation between the experience of social adversity and support for violent radicalization. So this is important because there was a strong mediating effect of depression. And we tend to think, and if you hear, I don't know, your different countries, people have focused a lot on the depression and anxiety effect of the pandemic. Again, we're thinking of acute stress reactions. And I think it's very important to think that tension, conflicts, violence are and will be very important outcome of the pandemic. They were this social tension linked to inequality and inequities were already present before the pandemic, and really the pandemic fueled them in a very powerful way. What is important in those results is to see that these forms of cumulative adversity are linked to a lot of psychological distress, but this leads to more adherence to conspiracy theory and more legitimation of violence onto others. So people want to get out of the helplessness, hopelessness paradigm. And a way to do so is to say, have a scapegoat, and a scapegoat that you can beat, somebody you can fight against, you know, and multinational, it's just impossible to fight against them. So you'll find the weak other that you can beat. And for men, that will be a woman, and sometimes the kids. And for, of course, women can also retaliate. And for the majority, it often, and if you look at Europe and North America, it will be the minorities, it will be the ethno-racial groups, it will be the immigrants who suddenly, just like in the Middle Age, become responsible for the uneasiness and the feeling of helplessness, hopelessness. So it's very important to see helplessness, hopelessness were experienced by the whole population, but do have more severe consequences for minority because of the social fracture they're associated with. Very rapidly, these have direct consequences on action, and I wanted to address it in the field of vaccination hesitancy. I could have done it also in the field of health communication, of course, social action, schools, and so on and so forth. Vaccination hesitancy exists in the world is world, but a lot of our country have not considered very much the effect of cultural and, of course, migration diversity on vaccination hesitancy. Because of all the reasons I discussed before, the stigma during the pandemic, the fact that they were over-affected in terms of mortality, morbidity, the distrust in institution, systemic racism. Melanie was talking about that very convincingly in access to vaccination, and the fact that health communication are tailored for majority and do not take into account the minority issue in terms of confidence and in terms of convenience, which are key in vaccination hesitancy. So, of course, for this varied from community to community. For the Asian community, stigma, discrimination, and racist crime were key. Vaccination hesitancy was fueled by that, even if they had a high rate of vaccination. Remember also, and Melanie could have talked about some bad experiences with vaccination, for example, in the Philippines, with the dengue vaccine. So you have to take into account historical memories and the present status of stigma if you want to address vaccination hesitancy. For the First Nation, with the terrible death of Joyce Echaquan in the health system in Quebec during the pandemic, the colonial past and trauma clearly interfered with vaccination and with trust, and it had to be addressed. And this is very difficult and putting First Nation communities in danger. Very true also for the Afro-Caribbean communities, in which some religious discourse, and it's interesting because social media messages coming from Africa very often, in a lot of cases, were more helpful. But then we did have the influence of our powerful neighbors, and Roberto can comment on that, and that was more difficult. So maybe just to conclude, coming back to my first statement.
Thank you that you can conclude.
Okay, thank you. Sorry for going too much.
Okay, thank you, Professor Cecile Rosa. So I think your presentation is very meaningful and informative. Yeah, maybe we'll go to the when the people have the question, we can just you can answer a question in the Q&A. Okay, now I would like to introduce our next speaker, with Professor Winnie Mak. Winnie Mak professor is a professor at the Department of Psychology at the Chinese University of Hong Kong. So now, just welcome, Professor.
Thank you. So good morning, good afternoon, and good evening. I really appreciate the previous three speakers, focusing a lot on the structural issues, social inequities, and a more macro levels, looking at how COVID affects many different groups. In the coming 15 minutes, I'm going to take a different focus in addressing today's topic. It's about how we are all interconnected and potentially how we can use that interconnectedness to reduce stigma towards people with mental illness. So just appreciate my team members for doing a lot of those research studies that I'll be discussing later on. So the way we, I think this is nothing new to the audience, that taking an ecological model of stigma, because stigma is being permeated across and within different layers of our ecology. So looking at how structural discrimination and how cultural beliefs may impact the way we understand different groups and how different groups interrelate as a result. There's also the issue of how individuals and families relate to people with mental illness, and finally how the person themselves may internalize some of those issues and receive and experience self-stigma. So in this ecology, we are all interconnected in a sense that we can look at it in a more positive way in how this interconnectedness may actually be used to our advantage to leverage and to level inequities. So just a little bit of the overview. I think this is nothing new. We know that mental illness stigma is pervasive across different countries. Graham, Thornycroft, and Lasavia has done a number of large-scale studies looking at how schizophrenia and major depressive disorder stigma is prevalent across these individuals with a negative discrimination and anticipated discrimination. This more recent studies looked at 229 countries, and what is interesting is that we notice a big difference between developed and developing countries, especially on the parity between mental illness and physical illness. So, and then Professor Ren also have done a review of 41 studies looking at both self-stigma and public stigma across different countries in the Pacific Rim. And we do find a very large variation, but nonetheless, self-stigma and public stigma is also very prevalent. So some of the possible reasons for these cultural differences may be from the structural stigma point of view is barriers in access and quality of services. We have a long history and ongoing stigma and discrimination against people with mental illness, as well as many different groups of minorities who are being minoritized actually, and and disenfranchised. And there's also a resource allocation issue. From a public stigma point of view, there's a lack of knowledge and misconception towards mental illness, and cultural beliefs also may impact the way individuals internalize these public stigma, which I'll later share. And for the families, there's a lot of courtesy and affiliate stigma, where especially among Asian cultures with strong familialism, there's also a strong issue of face concern, how someone with mental illness in the family may impact the entire family. And finally, self-stigma is maybe perceived themselves as having a personal weakness, and they're worried about being perceived as quote unquote crazy. So in this studies that we just recently published in the clinical site review, we looked at 108 data sets with, cutting across 22 cultures. Using meta-analytic structural equation modeling, we found that actually experienced stigma and perceived stigma is mediated through self-stigma in impacting psychological distress. And this model actually is applicable across 22 cultures. And then among these 22 cultures, we further code each culture using the in-group collectivism practice index, which basically measures the enactment of cultural values and how cultural groups have towards their family and their close in-groups. And through the mixed effect three-level meta-analytic model, we do find that collectivism moderate the relationships between experienced stigma and perceived stigma on self-stigma. In other words, for more collectivistic cultures, there's a stronger relationship between public stigma and self-stigma. So moving right along on how mental illness and stigma, exacerbated during the COVID-19 pandemic. Actually, the earlier speakers have already addressed this very in great details and with a lot of findings. In these two meta-analysis, we do find that across, again, different countries, there's a surge of depression and anxiety across different communities. And there's also a COVID-19 stigma across different regions, especially stronger among Asia, Africa, and Latin American and Caribbean countries than European and North American countries. And this, again, I won't go into details because Cecile has very nicely talked about it already, that Asian and Black participants report higher levels of related discrimination and stigma in Quebec. So what this means is that how COVID-19 may affect the way we see mental illness. Again, through a ecological model, there's an interaction between COVID-19, how that may exacerbate it, mental illness, as well as stigma towards COVID-19, different ethnic groups, and as well as people with mental illness. So there is the intersectionality actually is quite interesting. On the one hand, let's say in Hong Kong, we do see that there's a stronger discussion on depression and anxiety in the community. It seems like the pandemic makes it more easier for people to admit and recognize mental health issues. There seems to be a slight reduction in stigma in terms of anxiety and depression. But on the other hand, we also see that the challenges faced by people with mental illness during the pandemic may be exacerbated. There's longer waiting time, fewer resources, and they may not, because of vaccination, they may not go to or be willing to go to the hospitals or outpatient clinics for their consultation, which may complicate their health issues. Mental illness may also be perceived as less serious and less prioritized compared with COVID-19 infection in some parts of different regions and the world. And there's also, again, xenophobia that compounded the stigma experience, especially by Asian and specific groups of Chinese, specifically mainlanders and even Wuhan Chinese. So back to my original proposal on how interconnectedness may be used to enhance public responsibility. So let me introduce what is interconnectedness. It's borrowed actually from a Buddhist wisdom of dependent origination and what Thich Nhat Hanh coined as interbeing. And what that means is that we do have an awareness that the existence of all phenomenon in the world is a result of the fulfillment of different causes and conditions in which no entity can substantiate independently without relying on other factors. So essentially, we understand that all matters in the world are interdependent, and that we do have a role to play in contributing to each other's. So back in 2020, we developed and validated the interconnectedness scales and found that interconnectedness is related to better well-being, less psychological distress, and stronger endorsement of social justice ideologies. And then, so by applying interconnectedness on stigma reduction, we think that by raising people's awareness on the interdependence, and then understanding that stigma is a result of psychological, social, and cultural factors, one may play a role in contributing. This awareness may put people in a position to reduce stigma of minoritized groups. And they're more also likely to act compassionately to reduce the suffering of people who are being minoritized. So we went ahead and looked at the relationship. And we do find that interconnectedness is mediated through compassion and directly related to social distance and personal efficacy. Here, social distance is related to stigma instead of the social distancing that, that we have been talking about in relation to the pandemic. And social distance actually is coded negatively. So the positive correlations means that higher the interconnectedness, the less social distancing the person will have towards people with mental illness. So we also tried beyond the cross-sectional data to looking at interconnectedness using a one-year longitudinal survey. And through our random intercept cross-stack panel model, we do find that interconnectedness can consistently predict higher frequency of collective action participation towards people with mental illness, or for people with mental illness, meaning that they're more likely to call out for people who have discrimination against people with mental illness. They're more likely to participate in public protest and sign petitions and lobbying and other social advocacy actions. And in the relationship, we do find that compassion cannot mediate a relationship. So interconnectedness compared to compassion, it seems that interconnectedness has a stronger play a stronger role. So as a psychologist, we also try to get down to the causality of this issue. So we did some experiments to looking at how interconnectedness may be actually related to stigma reduction in a experimental design. So in this experiment that was just recently published in Mindfulness, we randomly assign people into 3 conditions. So the first condition is interconnectedness. So basically people go through a 20-minute audio guide, recognizing and reflecting on the interdependence of themselves in relation to others and in relation to the society and the nature. There's also a 20-minute audio guide sending wish to different people and friends, people they dislike, and strangers, and all beings in the world. This is more like a loving kindness meditation. And finally, there's also a controlled condition. And what we found is that looking at the 2 conditions, interconnectedness is related to follow-up and then post-experiment interconnectedness and compassion. And that is related to follow-up personal efficacy. Whereas you notice that compassion cannot lead to interconnectedness. So what that means is that interconnectedness play a role in personal efficacy directly as well as through compassion. And more recently, we also tried to add on to the social attributional model of stigma. So as you may know that, oftentimes when we look at mental illness stigma, we explain it through attributions that bias genetic attributions, meaning that is born that way, is innate, is genetic. Psychosocial is related to the family and other personality issues. And then we try to add 2 more attributions. One is the societal attribution, meaning that how the mass media, social policy, and social structures may contribute to mental illness stigma. And finally, personal responsibility and personal attributions, meaning that how a person themselves may be contributing to the onset and also the perpetuation of mental illness stigma. So through this model, we find that actually interconnectedness is related to most of the attributions. Just a few minutes, I'll be done. And then, but then only personal attributions is significantly related to social distance, but not the other traditional attributions that we see in the literature. So so we did another experiment trying to control and look at the causality of public responsibility and interconnectedness through 4 conditions, which I would not, elaborate too much. So basically, we have biopsychosocial, we add on societal attributions, and finally the personal attributions. So in this graph, we found that actually conditions with personal attributions actually can be is related directly with public responsibility, and having that sense of public responsibility is directly related to reduce social distance and heighten personal efficacy against for people with mental illness that traditional biopsychosocial cannot do in this model. So this is the final slide, actually. So I want to conclude that by recognizing that we are all interconnected, we can potentially tackle stigma at multiple fronts and levels. And we also need to recognize the intersectionalities of identities, which may exacerbate stigma. And by raising the awareness of our interconnectedness, and then enhancing the traditional attributions by including personal contributions to social causes, we can enhance people's public responsibility, and then which can reduce stigma and prompt social efficacy. So that's the end of my presentation. Thanks.
Okay, thank you, Winnie. Yeah, very interesting and informative. I'm so glad you share some studies. Yeah, very good. So now it's time for the Q&A. Maybe from the Q&A, I found a question. Just maybe the first question is maybe for the Cecile. Maybe what we are studying right now is what migrant idioms of distress concerning COVID. Specifically, explanatory model by using the CFI. Any of you, when you want? And my question is about what are the explanatory models of Asian migrants and First Nation patient in Canada regarding a virus that is infecting them?
It's a very important question. In fact, I think that the explanatory models with respect to COVID should be looked both in majority and in minorities because it's very heterogeneous. So I would say in terms of the global structuring factors, for example, in the Asian community, what we found more is a predominance of medical models of understanding, which do not mean that there is no adherence to alternative social, critical, or conspiracy theory. One of the problems now with the explanatory model is a tendency to divide, to say either you have a medical view or you're a conspirationist. Well, reality is not that simple, and we do have data on that, which show that to take into account the explanatory model for the COVID, you have to take into account education, of course, ethno-racial migration status, and the type of job, and the age, and the gender. So you see, it's really an intersectional appraisal of explanatory model, knowing that what we found is a range of explanatory model. For example, some people have been vaccinated, but are very critical of state government and the healthcare interventions. And they are often considered as conspirationists, but they're not the QAnon people who said the virus do not exist. So you have this whole range. And I think that rather than a determination by ethno-racial group, what we find is an intersectional determination, which put together, depending on your age, your relation on internet, your level of education, your social capital, your level of employment, you will have a different explanatory model vis-a-vis the COVID.
Thank you. So another question just from another person, just about often the concept of individualistic and collective cultures are mentioned in teaching and research. Is there any way in which countries or cultures can be measured on this spectrum? Any methodological consideration or recommendation? Maybe this can be for Winnie or maybe
Yes,
for Cecile. Okay, both of you, yeah, I think, yeah.
Okay. The Global Leadership and Organizational Behavior Effectiveness, for short, which is GLOBE research project, has published a list of measurements on way they code different countries by collectivism. So they have what I call like the in-group collectivism practice index that you can look up and then code each country. That being said, is a very crude measure. So because after all, there is a lot of heterogeneity within each country and a lot of heterogeneity among individuals. So for us in psychology, we often looked at the individual level, looking at self-controls and different cultural orientation that the individuals may endorse. So that way we can look at it in a more nuanced way instead of just a very crude measure of individualism and collectivism at the country level.
Thank you. So given the time, maybe the final question I can just from the former president Roberto. Yeah, just for I think maybe this question can for one of the four speakers. Just how can we people working in the culture psychiatry help mental health provider become active at the social level as advocate and to think contextually rather than just individually? Any of you? Yeah, can help. Yeah, please.
Okay for you, Winnie. I think we do have a crucial role. So the whole idea, we tend to think that a role is limited to the clinical space. And of course, clinical practice and training and informing clinician in the whole health system, even general practitioner of what's going on is very important so that they become sensitive of the patient predicament during crisis. Now, beyond that, and especially of the violence issue, which tend to be overlooked, but beyond that, I think that we have a crucial role in terms of informing culturally sensitive public health policy and social policy. Because if we take the WHO definition of mental health, our role is really to promote people's well-being. And there is a variation from community to community. And for example, the confinement rules, the priority given to what is going to open first. Is it the barbershop or is it the mosque? This is cultural, and we should inform and give a voice to minorities so that the priority is not always the majority. Otherwise, it really kind of increases the feeling of distress. So yes, we do have a very important role.
Okay, thank you very much. Yeah, given the time, I do think just I want to thank all of you. Yeah, for giving a wonderful presentation. Given the time, I also noticed many questions, but given the time, we cannot ask you the question. And so now I want to thank to all four speakers who give us such interesting and meaningful presentation on the stigma of mental illness and COVID-19 from a cultural perspective. Their knowledge and experience of stigma in different countries and regions such as UK and Philippines and Europe and Canada and Hong Kong are very helpful for us to comprehensively understand the stigma of mental illness and COVID-19. Stigma and discrimination can cause severe negative impact on mental and physical health. All of us should work together to fight the stigma of mental illness and COVID-19, develop more effective crisis responses and intervention, and improve the mental and physical health of population, especially minoritized and marginalized community. So after this seminar, the special interest groups of culture, stigma and discrimination, and culture, psychiatry, and COVID-19 pandemic of the World Association of Culture Psychiatry will organize more activity next year, such as seminar or webinar next year. So we welcome all people who are interested to attend the activity. So thanks all speakers and participants again. And goodbye to all. Thank you. Thank you very much.
Thank you, Maosheng.
Thank you.
Bye-bye, everybody.
Bye-bye.
Bye.
Bye. Bye, everyone. Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye.
Bye-bye.
Bye.